started right at 1:15. Maybe being in person at SPA National this weekend kept me from spending 5 additional minutes catching up with all of my favorite people who are presenting on the webinar series, like Dr. Kotlar today. He is no stranger to our webinar series. I love having him on a couple of times a year, and I couldn't imagine not addressing this subject without having him present. There's so many questions about changes coming up in 2021, and I can't think of anybody better. Many of you might recognize him. He's the president of Target Coding. He owned and operated a successful chiropractic practice for 12 years and a multi-specialty practice for 4 years. He began consulting with a special emphasis on CPT coding, billing, reimbursement, documentation, and compliance for chiropractic and multi-specialty facilities. And over the last more than a decade, he has provided valuable nationwide educational seminars and consulting to thousands of healthcare providers and their staff. He has numerous certifications in all of his areas of expertise, which is why he's one of my go-to people, especially when I have questions about coding and documentation. So, Dr. Kotlar, thank you so much for being here today.
Well, thank you, Christy, for having me. I want to thank everyone over at ChiroHealthUSA for inviting me to do these webinars. I certainly enjoy doing them. I hope everyone else likes them too. A little bit about myself. Actually, Christy gave me a very nice introduction. I'm a chiropractor. I'm also a certified coder, and I kind of consider myself unique because most chiropractors are not certified coders. Most certified coders are not chiropractors. So you'll see how I, combine those two specialties to make sure you're doing things properly, you're complying with laws and rules, and you're getting reimbursed what you deserve. So there are quite a few changes that are coming up in 2021. One of the most important changes that are coming up in 2021 are to the new patient E&M codes. E&M stands for Evaluation and Management. And I'm sure many of you, if you've been in practice for a while, you're familiar with these codes, 99201, 99202. These are the guidelines that you see on your screen. Let's go to 99203. This is the most commonly billed new patient CPT code. So the present guidelines state you have to document a detailed history, a detailed exam, and decision-making of low complexity. So those are the things that are going to be changing starting in January 2021. So let me just go over the present guidelines. The present guidelines state that 99203 requires that you document at least one chief complaint, 4 HPIs. HPIs is the history of present illness. So for example, or in chiropractic college, you may have been taught it as the OPQRST. So, for example, Mrs. Jones comes in with neck pain and back pain. She says her neck pain started 3 days ago, and she woke up with neck stiffness. These are all HPIs. It's throbbing. It's dull. Lower back pain started many years ago. That's an HPI. Pain scale. So these are all the items that at the present time, and for the last, say about 25 years, we've had these guidelines. These are the present guidelines that I'm going over with you from 1997. There were two guidelines created back in 1995, and then actually one in 95 and one in 97. So those guidelines have been around a very long time. So now they're changing. So for the past 25 years, this is what you had to do when you bill a 99203. Document the chief complaint, 4 HPIs. You have to review 2 to 9 systems, 1 item from the past family social history. So these are all the things you should be doing now through December 31st when it comes to your exam portion of the 99203. That requires 12 exam findings. These are changing. So, and these are the things you should be doing through December 31st. Hopefully you've been doing them. You've been in practice for many years. You've been doing this all along. And a lot of people say, well, where do you learn all this stuff? Whenever I do, Christy, you probably get the same thing. People come up to you, maybe more CAs than doctors, saying, how do you know all this stuff? Where do you learn all this stuff? How did you get so smart? It's basically reading. I mean, this is what I do. Most of the week, I'm reading guidelines, the E&M guidelines. What you see there on your screen in the top left corner, those are the guidelines that were created back in, 1995 and 1997. And those are the guidelines that are supposed to be followed. Now they're changing. I'm going to go over those in a minute. So that's where I get my information from, the E&M guidelines. When I talk about diagnosis coding, it comes right from the ICD-10 guidelines. When we talk about CPT codes, like your 98940, 41, 42, your 43s, your rehab codes, modalities, comes from the AMA guidelines. Medicare, I don't like to guess when it comes to Medicare. So when I teach Medicare, it's basically right from the Medicare guidelines. And then I get specific. If the doctor's from Mississippi, I'll teach the Mississippi guidelines. If they're from California, it gets specific when it comes to Medicare and HIPAA, of course. You have to follow that. Another important item presently with your exams and re-exams is your decision making. 99203 requires low complexity decision making. So just to going on presently through December 31st, when you bill, for example, 99203, that requires a detailed history. Just went through that. What is that? 1 chief complaint, 4 HPIs, 2 to 9 systems, 1 PFSH, exam, 12 exam findings, and decision making of low complexity. You got that? Well, here we go. January 1st, 2021. Forget everything I just told you. There are historic changes. Yeah, according to the American Medical Association, these are historic changes that are occurring to the documentation requirements for 202 through 205 and 211 through 215. These are your new patient codes and your established patient E&M codes. So the big difference is you're going to be choosing the code based on either decision making or time. Yes, decision making or time. It's not based on 4 HPIs, 2 to 9 systems, 12 exam findings. You're supposed to be doing an appropriate history and an exam, but when you submit your documentation to an insurance company for your new patient codes or your established patient codes, it's going to be based on either decision making or time. Yes, time is back. If you were in practice back in the late 80s, early 90s, time used to be a key component. Back then and back in, I think it was 1992 and 1993, time didn't become a key component. It was taken away because of the new E&M guidelines. Time was taken away as a key component. Well, it's come back. It's come back. And by the way, these changes are good for doctors of chiropractic. As I mentioned earlier, I'm a chiropractor. I practiced for many years, so I know what it's like to be in the trenches treating patients and documenting and do all that stuff. And now I'm an expert in billing and coding. I know what is needed to satisfy an insurance company audit or review of records. So my opinion on these changes, it's good news. As healthcare providers and experts, in the chiropractic billing and coding industry, usually when you hear something, it's negative, right? Oh, here comes a decreased fee schedule, or here comes more documentation requirements, or more stuff we have to do, ICD-10 and all this. Well, here's good news. This is going to be good. There's going to be less burdensome paperwork on providers now, because it's based on decision making and time. So if you purchase a 2021 AMA CPT code book, or basically any basic CPT code book for 2021, you're going to see different language. You see, look at all the stuff that's crossed out. All the stuff that's crossed out is the stuff that you're required to do now through December 31st. So when you get your new code books, it's going to say for 99203, evaluation and management for a new patient, which requires an appropriate history and or examination, and low-level decision making. And if you're going to use time as a key component, it's 30 to 44 minutes. And that includes face-to-face and non-face-to-face on the day of the encounter. Okay, so if you're going to use time, you have an option. You could use decision making or time. Let's say you choose time. And let's say Mrs. Miller walks into the office with x-rays, MRIs, and she gives them to your CA, and then your CA gives them to you, and now you're in your back office, and you spend 20 minutes reviewing Mrs. Miller's MRIs and x-rays and maybe CT scans and maybe lab work. You haven't even met her. She's in the office. Maybe she's in the waiting room filling new patient paperwork out. You haven't met her. Or maybe she's in the exam room waiting for you. You've spent 20 minutes before you even spoke to her going over her x-rays and films, and that 20 minutes counts towards the 30 to 44 minutes. So you got 20 minutes now. Now you go in and you have a discussion with Mrs. Miller. Let's say you speak to her for 10 minutes. You already have met the 99203 requirements without even doing an exam. I'm not telling you not to do an exam, but if you don't do an exam, you have already met the requirements. 20 minutes reviewing records and 10 minutes doing a history. There's 30 minutes right there, which would qualify for a 99203 without even doing an exam. Now, please understand, I repeat, I am not recommending you not do exams. You need to do an exam. But looking at the definition, you don't have to. There's your 213. See, look at all the stuff that's crossed out. 99213, that's your re-exam, established patient, which requires a medically appropriate history and or examination and decision making. You see, decision making is there for time, 20 to 29 minutes for a 213. So as far as decision making goes, I'm not going to spend too much time on this because just explaining this chart takes about an hour. So I'm not going to get involved too deeply in this, but this is the decision-making chart. It's not that different than the existing table of risk. It's just much easier to interpret, believe it or not. You might be looking at this and going, wow, this doesn't look easy, but it is going to be much easier, and everything's leveled up, I call it. Like with the existing E&M codes, 99203 has the same requirements as 99214. 99202 has the same requirements as 99213. January 1st, it's not going to be the case. 202 and 212, same exact requirements. The only difference is it a new patient or an established patient, but the documentation requirements are the same. So I call it, they leveled them up. So if you're going to use decision making to determine what code to use, this is the chart. So for example, let's take a look at 99203 or 213. The level of decision making is low. Then the number and complexity of problems. Okay, so let's say you have, let's go to the bottom one where it says one acute uncomplicated illness or injury. What's an example of an acute uncomplicated illness or injury? A sprain, cervical sprain, lumbar sprain. That would be an example of one acute uncomplicated illness or injury. Then we go to the next column, amount of data to be reviewed or analyzed. Let's say it's minimal or just x-rays, minimal or none. Okay, so that's in the 202 category. Then the risk is low. Somebody comes in with a sprained or strained muscles or ligaments, the risk is low compared to somebody going to an emergency room with a stab wound and they're hemorrhaging. The risk of morbidity or mortality is high. So that's how you read this chart. And you only need 2 out of the 3 elements. So you have one acute, minimal or no data to review, and low risk, there you go. There's a 203 or 213. Now, if you're going to base it on time, look at the time. Well, first of all, look at 99201. In January of 2021, 99201 will not be available. It is going to be deleted. So some of you may be using 99201 on your pediatric patients, your infants, very low level situations. You're not going to be able to use that code anymore. It's being deleted. January 1st, 2021, no more 201. Say goodbye to that code. And then if you're going to bill, let's say a 203, you see the time? It's 30 to 44 minutes. Right now, it's about, you see it says typical, about 30 minutes. And then here's your 213, 15 minutes presently, about 15 minutes. Well, January 1st, 29 minutes. Next thing you should be aware of is what's going to happen as far as the fees. Well, in 2021, the relative value, the RVU, relative value unit, the work portion of the RVU is going up on all of them. Well, for 202, it's staying the same. For 203, it's going up from 1.42 to 1.60. So, in theory, you should be getting paid a little bit more for your 203 starting in January. Medicare will have a higher RVU, although the fees are going down. We'll get to that in a minute. But there will be an increase in the RVU. For 99211, stays the same. 213, it goes from 0.97 to 1.30. That's the biggest increase out of all of them, I'm pretty sure. So that's a good one. Fees are going to go up. Next, there's a new code. So if you spend, let's go back and take a look. Let's say on a new patient, you spend more than 74 minutes. Look, 99205, the range is 60 to 74. Let's say you spend 90 minutes. That's an extra 15 minutes with the patient. So then you would bill 99205 and then 1 unit of 99XXX. I'm pretty sure that's going to be the code, triple X. I don't think that's just a placeholder. I think that's going to be the actual code. 99XXX, brand new code for prolonged services. 15-minute blocks above your 205s and your 215s. Next, there's a new code. Well, this code was born in September. It's a brand new code. It's an infant, little baby code. Usually the AMA releases codes January 1st of every year. Well, they didn't want to wait. I call this the PPE code. This is a new code. Again, just came out. You don't have to wait till January to start using it if you want to. This is additional supplies, materials, clinical time over and above those usually included in an office visit when performed during a public health emergency. So this is the time you spend pre-screening the patients, applying and removing the PPE, performing cleaning of your exam rooms, equipment, supplies, hand sanitizers, disinfectant wipes, sprays, cleansers. So if you're going to bill for this code, we recommend that you tell the patient in advance there's going to be a charge. Contact the health plans to verify coverage prior to billing. If you're out of network, you should be able to charge cash. If you're in network, you might not be able to charge the patient at all. So again, check with the carriers prior to billing, and you're going to need to keep track and document the costs to your practice for the PPE, the additional time spent, taking the temperatures, completing the questionnaires, cleaning supplies, disinfecting the office. All right, next, a little update on modifiers 59 and GP. The AMA owns the copyrights to the codes and the modifiers, and modifiers is just a way in which you can tell a health plan that the procedure or service or product, it's been altered somehow, some way. Maybe there's a professional component, a technical component. Maybe only part of the procedure was performed bilateral. There's many different reasons why you would use modifiers. Now, 59 is a very common modifier. It means it's a distinct procedural service. Distinct procedural service, very common on your 97140. That's manual therapy. Why? Because of the CCI edits, the National Correct Coding Initiative edits. These edits massage therapy and neuromuscular be performed in a separate anatomic site. So if you do that, that's when you use the 5-9 modifier. Now, the 5-9 modifier has been an issue many years because it's one of those rare modifiers that bypass the CCI edit, so it gets used incorrectly often. Not that recent, an OIG report probably about, 8 years ago now, found that Modifier 59 was billed incorrectly nearly 40% of the time, resulting in over $50 million in overpayments. That's why I tell my clients, do not use 5-9 if it's not necessary. A lot of doctors are using the 5-9 modifier on all their codes because they heard that's how you get paid better. Why use 5-9 on 97110 or 97012 when it's not necessary? It'll raise your profile. So careful with the 5-9. Now, because of all the confusion with the 5-9 and the problems, Medicare created these 4 new modifiers. Well, they're not that new. It's probably about 3 years now. A subset of 59 called the XESPU modifiers. So down the road, you may need to use the XS. I'm not telling you to use the XS today. Don't change anything you're doing based on this webinar. Contact the plans. Make sure you know what you're doing. Vet it or contact me after. I don't think it would be a good idea for you to just all of a sudden change your 5-9 to XS. That'll lead to possibly more denials. If you're using the 5-9 properly and the claims are getting paid properly, then don't change it to the XS. But this is what happens with some doctors or the staff. They contact us at our help desk and they go, Dr. Kotlar, I don't know why. Now we're getting denied. It says missing modifier, wrong modifier. What happened? We've been getting paid no problem. Well, in that case, this particular health plan may have changed their policy without letting you know in advance. So that, in that case, you may need to switch to the XS. The GP modifier, also an issue with a lot of doctors based on the calls we get at our help desk. Modifier GP is a Medicare modifier. It means that the service was delivered by a physical therapist or in a PT plan of care. So why should we have to use it? Well, there are some health plans that say, if you don't use it, we're not going to pay. Or if you don't use it, and this is a Medicare secondary, and you don't use it, then Medicare won't process it properly to get over to the secondary. So the GP modifier, I would strongly recommend you use it on your 9-7 codes when billing United Healthcare, because if you don't, you probably won't get paid. Next, the new Medicare ABN form and the 2021 Medicare deductible. Just a quick review here with Medicare. You know, there's all these different Medicare plans, Part A, Part B, Part C, Part D. So when someone turns 65, you automatically get A and B. A, hospital, B, doctor's visits. So patient comes in. Here's another thing we train our CAs. When a patient calls and says, hi, I'd like to come in, and the front desk CA goes, okay, do you have insurance? And the patient says, yes, I have Medicare. Oftentimes, the front desk CA will put all the Medicare patients into one bucket. That is not a good idea. When a patient says, I have Medicare, first of all, the patient doesn't realize that Medicare is not an insurance company. Medicare is a federally funded program. And then I think there are 8 insurance companies called Medicare contractors that process and pay your claims. So, for example, let's say you're in Texas. That's Novitas. Let's say you are in Illinois. That's National Government Services. So, depending upon that state, you will have an insurance company. So let's go with, Arizona. That's Noridian. Okay, so Mr. Smith comes in, hands you that red, white, and blue card. You know, if you're in Arizona, that's Noridian. That's the health insurance company, and that's going to only pay for spinal manipulation. Some patients now, this is actually the open enrollment time. You may be seeing a lot of commercials on television soliciting Medicare Part B patients to go into a Medicare Advantage plan. I see a lot of these commercials with Joe Namath and a lot of famous people trying to get people to come over to a Medicare Advantage plan. That is Part C. Part C is Medicare Advantage plans or Medicare replacement plans. I think you could interchange those 3 terms. So a patient comes in and hands you an Advantage plan card. That's totally different. Some of these plans will pay for exams and x-rays. I have some clients that are getting paid for orthotics and diagnostic testing with Medicare Advantage plans. So I just wanted to cover that so you know not to put all your Medicare patients into one bucket. Vet it. Ask the patient, let me see your card. What do you have? Primary, sometimes patients, they come in and hand the front desk 5 different insurance cards. And now what? So you got to figure all that out. Here's the new ABN form. It becomes mandatory on January 1st, but you could start using it today. The main difference is the expiration date. The old ABN form in the bottom left corner, it said expiration of 3/2020. The new one says June of 30, 2023, 6/30, 2023. So we basically break it down into 2 forms for Medicare Part B patients. The first one is on the first visit. Medicare Part B patients, let them know that Medicare Part B doesn't pay for exams, x-rays, therapies. They're responsible to pay. They sign that form. Now, when the patient reaches wellness or maintenance, then the ABN form becomes mandatory. If they check option 1, you need to bill Medicare, even though it's not going to get paid, by changing the AT to the GA modifier. And then, hopefully, I would prefer they check option 2, so then you don't have to bill Medicare. And now you have an actual, true cash patient coming in for maintenance or wellness. No billing. That's the goal, right? Isn't that the goal? I'm assuming that's the goal. Here's a question. So, Doc, when Dr. Kotlar, when the patient gets to maintenance, can we charge our normal fee? The answer is yes. And I like to give sources. I don't like to throw things out that are very important by giving my opinion. If you want to learn more about this, then go to the Medicare Claims Processing Manual, section 50.7.3. And just want to close with a few things you should do as far as educating your patients, financial patient education. This is where, ChiroHealthUSA comes in, and, because, patients come in. If you're out of network, there are these very high deductibles, and co-pays might be more than your cash fee or your ChiroHealthUSA fee. So you should have a policy on deductibles and co-pays and co-insurance, just to, share with you. No, here, deductible. For those of you that are brand new to chiropractic industry, doctors or staff members, I'll explain to you. A deductible is the amount that is paid by the patient prior to the insurance company kicking in. The Medicare Part B deductible for 2021 is $203. It's going up $5. Right now in 2020, it's $198. Co-insurance is a percentage that the patient is responsible to pay out of pocket. Copay is usually a flat fee that the patient pays. That usually is an in-network situation. So now here's my question. Is it okay to waive a deductible or a copay? The answer is maybe. Depends on the situation. For example, here comes Mr. Jackson. He comes in and he has a $30 copay. He forgets to bring his wallet. Next visit, again, forgets to bring his wallet. Third visit, forgets to bring his wallet. Now he owes you $90, doesn't show up for his next appointment. You call, doesn't answer, doesn't return, send a letter, disappeared. Owes you $90. You could waive that. You've made a good faith attempt to collect it. You could write that off. What's not okay is the routine waiver of deductibles, like saying all the teachers that come in, not going to collect the copays or deductibles. Or I have a client, he's in big trouble right now because he didn't listen to me. Wells Fargo Bank was right next to him. This wasn't an actual bank. It was an administrative building. About 300 employees working in this building. It wasn't a bank, just people sitting at a computer doing admin work. And this particular Wells Fargo had Cigna. And this was an amazing Cigna plan. Very low deductible. Maybe no deductible, pays 80% of everything that was billed. So he told all these employees, come in, I'll accept your insurance as payment in full. You don't have to pay anything. See, that's not okay, because he got a letter asking for proof that he's collecting payments. There was a whistleblower. Somebody called him in. I don't know. Maybe it was a disgruntled employee. Maybe it was a jealous chiropractor down the road. I don't know. But it was a key tam action. So it's not okay to do routine waiver. You may be accused of misstating your actual charge. If you bill 100 and you accept 80%, then your fee is really 80. That's what the federal government might say. Now, do you have policies on discounts? This is where ChiroHealthUSA comes in. Give your patients options. When you give them the option, hey, Mrs. Jones, have you ever heard of ChiroHealthUSA? No, what's that? Well, our normal fee is $180, but if you become a member of ChiroHealthUSA, it's only $45. What do you think? Well, most patients are going to be instantly pleased with that choice. So what is your policy on discounts? What are your policies, on free exams? Do you offer free exams? Is it okay to offer free exams? So prevention is the key. That's what I always say. Prevention is the key. Don't wait for the oil light to flash on your dashboard. Get out of the car, open up the hood, check the oil. Here's a little checklist. Create for billing and coding checklist here. Just a quick little checklist on billing and coding. Designate someone in the office to be the billing and coding office manager. Create policies and procedures, simple ones. It doesn't have to be complicated. Have open lines of communication with your staff. Get your staff involved. Show them that you want to be compliant. You want their input. You want them to help you. You want them to learn and tell you if they think something isn't going proper. Have formal trainings and log those trainings in your billing and coding policy manual. So those were a few of my closing comments. Christy, back to you.
Hi. Okay. Well, we have several questions that have come in. Let me go. The first question was, has CMS adopted this as well as far as the E&M?
The E&M changes were created by CMS and the AMA and input from many of the major insurance companies. So yes, this is across the board. Okay. Every single plan that pays for 9920 codes and 21 codes are going to be adopting these guidelines. That's why I'm telling my docs that do PI, if you don't document these exams and re-exams properly, it's going to be an easy way for the State Farms, the Geicos, the Allstates to deny your claims.
Great. And I guess that really was, it led into question 2, which is, are private payers required to follow suit for E&M code changes, or can they choose to continue to accept 99201 and 211?
They're not going to. If they do, it's kind of weird and unique and abnormal if an insurance company still pays for 99201. So that's up to, the health plan. But this is a HIPAA thing. Health insurance companies have to abide by HIPAA. Within HIPAA is following the CPT and ICD-10 standards. So, yeah, these are being adopted by everyone. So just assume that. Everyone listening to this, assume every health plan that you bill are using the new E&M guidelines. Until further notice, just go with that.
Okay. Several people were having some Wi-Fi issues and the sound cut out, and they were wanting to know if you could go back and review the modifiers, because that was the section they missed.
Oh, yeah. Okay. Modifiers, that's the part that got cut out. Okay. So, yeah, I spoke about 59, which is a distinct procedural service, which needs to be done on the manual therapy, massage, and neuromuscular because of the CCI edits. And then I also spoke about the GP modifier, which is required by some health plans. It means that the service was done by a physical therapist. We're not physical therapists, we're chiropractors, but there are some health plans, specifically United Healthcare, that is taking a pretty strong stance on this. And if you don't bill the GP on the 97 codes and your G0283, they probably won't pay.
doctor said that insurance companies have been denying 99212, saying it's part of the treatment visit, even when billed every 30 days. Do you have any thoughts on this?
Yeah. Depends on why the doctor did the E&M, like a 99212, 213. Many plans will pay for it if you do it to update the patient's situation. And then there are some plans, actually quite a few plans, that say, we will not pay for those codes unless the patient has a flare-up, an exacerbation, or they stayed the same for too long a period of time. So that's what I'm recommending. Doctors billing a re-exam. Just make sure your documentation could show it's separate and distinct, meaning you're going to do that anyway. Even if you weren't going to adjust the patient that day, you were planning on doing a re-exam. For example, you walk into the room, the patient says, I have a brand new problem, Dr. Kotlar. I know I've been coming in here for a neck problem, but I twisted my knee playing basketball yesterday. My knee is killing me. You must do a re-exam in that case. Now, will the health plan pay for it? I don't know. Maybe yes, maybe no. But according to the standards of practice in your state, if a patient says, I have a brand new problem, I have a knee problem, and you're going to be treating it, you have to do a re-exam. So I look at this clinically first. Patient has a flare-up, a new problem, an exacerbation, or I have to re-examine them after 30 days to get an update on their condition. I'm going to do that because from a clinical standpoint, I need to do that. Now, billing is second. Who's going to pay for it? That's secondary. Insurance doesn't pay, the patient should pay.
Okay. And they added the comment that they're not asking for notes before denying the 99212 as bundled. Would you recommend that they file an appeal on that?
I'm sorry, what was the question?
The comment that was added said that they're not asking for the notes before denying the 99212 as bundled.
So they're denying it before they even ask for the notes?
Yep.
Okay. So that's where the doctor needs to find out why they're denying it. Typically, it's because they say it's part of the adjustment. So that's where you appeal that. Use a good fight back letter. And I have a really good one. If anybody wants a copy of that fight back letter, send an email to amy@targetcoding.com. And you're basically going to say, disagree with your decision. According to the American Medical Association guidelines on chiropractic services, E&M services are indicated when the service is separate and distinct and goes above and beyond the usual pre and post service associated with the chiropractic adjustment. And then you send a copy of the notes for that day. It works pretty well.
Okay, so new question. At this time, South Dakota Medicaid only accepts 99201 and 99211 as E&M codes for payment. Is anyone aware of their state's Medicaid working on changing to be compliant with the new guidelines for 2021?
No, I can't help you. Contact them directly.
Will doctors need to put in the time, record time in the note for time-based codes?
I'm sorry, I couldn't understand the question.
Will doctors need to record the time for time-based codes in their notes?
Oh, yeah, you're going to have to. If the doctors are going to be using time, not decision-making, but you're going to use time as your way to justify your E&M codes, then you absolutely must document. So, for example, in your notes, and I have a webinar coming up next week that I'm going to be giving out sample notes. I don't know if anybody is interested. It's you can go to targetcoding.com. I don't know. Let me just. I don't know. Do you still see my screen?
I do.
Okay. So I'm just going to bring up my website. I'm going to show November 17th right here. If anyone wants to register for this webinar, I'm going to go into deep details on how to document time. I'm going to give example SOAP notes. I'm also going to give deep details on the decision making and how to use that. So But the example that I am going to give you right now, I actually mentioned it before. Spend 15 minutes. Your notes are going to have to say, I spent 15 minutes reviewing the patient's x-rays, lab work, and MRIs prior to the exam. Then spent 10 minutes doing the history and spent 15 minutes doing the exam. Total time, 55 minutes equals 99204. So yes, absolutely. That is one of the big differences between what you're doing now. Right now, your E&M codes are not time-based. So what are they based on? They're based on the amount of exam findings, your history, your past history, family history, review of systems. That's all going away. So next year, if you're going to use time, you have to document and write down the amount of time. Just like if you're doing, let's say, therapeutic exercises. That's a time-based code. Or ultrasound, 97035. You have to write down the amount of time you're doing that because it's a time-based code. So if you're going to use time, you must document it and put down the total amount of time that you're doing all your services, or document your decision-making points.
Is there a new LCD for chiropractic in Florida with FCSO? I know they retired L36617 as of 10/1.
Yeah, there's a new one. I was just looking at it the other day. So whoever wants that, I mean, you can go to medicare.fsco and you can find it. It's pretty easy to find under their policies, under LCDs and articles. Now, many of them are not called LCDs anymore, by the way. When you're searching for them, they're moving to what is called as articles. So it's there, but if for some reason you go there, you can't find it, send an email to amy@targetcoding.com and she'll send it to you.
Who decides what is the appropriate level of exam history for the new exam codes? It feels like it leaves room for insurance to make arbitrary rules, not the time the other aspects of the code rules.
Is that a comment or a question? I'm sorry, I didn't.
I think the question was, who decides what is the appropriate level of exam and history for the new exam codes?
Yeah, I mentioned it earlier. CMS, AMA, and the major insurance companies all got together and created these new guidelines.
Okay. I want to clarify the time is same day for E&M codes. So if the doctor does exam and we request records reports from elsewhere and they don't come in for a day or two, the time reviewing that material doesn't count toward the E&M time?
Not on that day. It's on the day in the encounter. So let's say 3 days later or 3 weeks later, you get all the MRIs and the lab work and you have to spend time going over all of that. Then on that day, you'll bill based on the amount of time. You'll use the established patient E&M code. So for example, maybe a 99212 if you spend 20 minutes.
With an E&M code, will 50% of the time satisfy the full-time requirement?
No, that's the old way of figuring out the time. If you're using counseling and coordinating care, then time becomes the key component if you spend at least 50% of the time counseling and coordinating care. That's old. It's around till December 31st, but January 1st, no, it's not based on 50%. Now, for the other E&M codes, like there are probably 50 to 100 E&M codes. Chiropractors, we only use the ones that I've been referring to, but if you were in a hospital, medical doctor, there are other E&M codes. The counseling and coordinating care and the 50% time, that still applies to those, not to the ones that I just went over.
I don't see anything else. We've had several people who wanted to know if they could, or who are requesting a copy of your slides.
No, if you attend this one that I think you might still see on the screen, these include the live webinar, all the PowerPoint slides, and the recording, just in case you didn't make the live event. So this one includes the slides, live and recorded. It's November 17th from 1 to 2:30 Eastern.
If we bill for reviewing records on a separate visit, would there be a copay for that, or would it count as a visit if they have a limited number of visits?
It would count the same as it does today. Whatever it counts today, assuming that the insurance company doesn't change anything, only that the documentation requirements change, then follow the same rules. If you bill, whoever asked that question, if you did a re-exam today and or you did counseling and coordinating care for like 15 minutes and you wanted a bill in 99213, what do you typically charge the patient today? It'll be the same January 1st. What do you have to document? That'll change. What you get paid, it might go up.
Okay. Is there a printable resource available with the criteria for decision making?
Yeah, November 17th. And, it's right here in the slides that I went through, decision making. Here, I'll show you. Somebody right here, decision making. I'll make it a little bigger. This is what it comes down to. Here's the summary. It's either MDM or time. Medical decision making or time. Now, if if you can't make my webinar, you don't want to come to my webinar, that's okay. No problem. Just Google the new E&M guidelines. You'll probably find tons of information out there. There's a lot of free information out there on the E&M guidelines. It just gets, when it comes down to these, these charts here, this is where a lot of doctors lose it. This is where a lot of staff members like, oh man, I don't know. What do I do here? What do I pick? That's what we're going to be going over in detail at my webinar. And, you might be able to find some free webinars, that go over this in detail.
I was looking to see. Here we go. All right, let's see. Can you tell us about the 2021 Medicare rates?
Probably going down up to 9%, I've heard.
Yes, and I would definitely, all of the state associations have been really trying to communicate with their members and non-members about that and what they're trying to do to help prevent that or to not be as much of a decrease in your fees. So definitely reach out to your state associations. They do have a lot of resources available.
Oh, yeah, definitely. Contact, if you want something to get done, you have to join your state association. You have to join a national or state association, donate money. If you don't have the time to help out, donate money. I donate a lot of money to many different state associations throughout the country to, help fight these things. So, yeah, from my reading and my interpretation as to what's going on, there's going to be a 5 to 10% decrease in Medicare reimbursement, Medicare Part B. And the reason is, again, from my alerts and bulletins and news papers that I read on billing and coding, it's because money is being put towards telehealth and opioid treatment. So if you give more money to one thing, you got to take money away from other things. That's the way it seems to work in Medicare. So that's why there's going to be a decrease in reimbursement. It's not definite, but probably will be.
Yes. So definitely, like I said, I know this is top of mind awareness for all of the state associations right now. And I strongly encourage you, reach out to your state association to find out more information. And what it is that they're working on to, again, to tackle this issue. So please reach out to them. They're an incredible resource that you should be utilizing in your state. Y'all have no idea just how amazing. Well, you probably do know how amazing they are, but don't hesitate to reach out to them, especially about this issue. So, Dr. Kotlar, you want to talk about your free consultation?
Yeah, if anyone's interested in setting up a free consultation based on what we spoke about today or anything to do with chiropractic billing, coding, documentation, Medicare, HIPAA, send an email to info@targetcoding.com. And then we have really fancy software right now. You send us an email, we'll send you an email back with a link with our calendar. You pick the day, grab a slot, find something that's convenient for you and me, and we'll chat for 15 minutes. Pick my brain.
Wonderful. Yes, definitely check it out. Reach out to the team at Target Coding. Again, I also posted Amy's email address in the chat box, so you can reach out to her at Target Coding. They are so incredibly helpful. Like, I can't even say that enough. So please reach out to them with all of your questions. Reach out to Dr. Kotlar for that free consultation. Like I said, he's absolutely amazing. There's so much about so much information. And if he's not even the right person to help you with the situation, trust me when I say that he will refer you to the person who is. So make sure you reach out to him and take advantage of that opportunity. So I don't even know what we're going to be talking about. I don't think we have a webinar next week. But maybe, oh, yes, we do. Okay, see, y'all look at me. It's getting to be the end of the year. So next week, we have Mandy and Heather from ChiroHealthUSA. They've never been on our webinar series before, despite the fact that most of you already know them and know them really, really well. But they're going to be talking about your annual evaluation of your fees, making sure you're keeping stuff up to date, what you need to be looking at, and the resources that are available to you if you're a DIYer, to all the way up to utilizing a consultant to help make sure that you are going into 2021, you're charging market value, that you're not undercutting yourself revenue-wise. So make sure you check that out. It should be a lot of fun and a lot of laughs and very interesting, to say the least. That's going to be the last webinar of November, and then we have 3 coming up in December. One on how to start your own podcast in your community. And we're going to talk a little bit about compliance. That's going to be me. It's a one-man show that day. And then we're going to, again, have, talk some more about, 2021 changes, because we have lots of people coming on here talking about that. So we want to make sure we address it multiple times. And then that'll be a wrap for 2020, and we won't come back until mid-January for new webinars. So make sure you, again, share your feedback today. If there's a specific topic you want to see addressed in 2021 on the webinar series, let me know, because I take that stuff very seriously. If there's a specific speaker that you're looking to hear from that we have not had on here, or maybe you haven't had on here in a while, again, let me know, because again, that's how I make those decisions about who to bring on here. So anyway, we're wrapping up a few minutes early.